Hello and welcome back to Talking Faces, your premier choice for facial aesthetics educational content. I'm Dr. Raul Cheto and I'm joined by my co-host,
Lee Walker, as always.
And today we're going to discuss anatomical risk areas. So this is a subject that we're all scared of, and we all are aware of potential complications we might have with our treatments. So we're going to boil it down to the top 10 risky areas that we treat with injectables. Lee, you have a lot of experience
Yes.
in complications. So
Unfortunately. I think we need to make an objective decision based around this. Do we have relative to vascular occlusion, relative to lumps and bumps and nodules, or do we have it relative to the risk? I think the number one fear that most injectors have is of visual loss. Absolutely. Or blindness. So I think we'll look at it from that point, because I feel that's one of the most, or is the most catastrophic complication that we've experienced so far here in the UK.
Absolutely, yes. So, I mean, there's, as you guys all know, there are several complications that might arise from injectable treatments, but blindness is definitely probably the scariest one. So, in terms of the top 10 areas of risk of blindness, number one, Lee, I think is one area that I'm familiar with from my previous background in ear, nose, and throat surgery, an area that I've operated on a lot. Which is the nose.
Yeah, I mean it's incredibly popular now, and I think with the advent of social media, really profiloplasty, those type of things. I don't think we ever considered touching a nose non-surgically. When I started, it was just basically nasolabial folds and lips.
Absolutely.
So nose is an incredibly dangerous area to inject, and I think from various publications, we're starting to see data come through to us about how dangerous this is. If we look at, I think the most pertinent one that we're discussing today is Katie Belasny's study on the review and of the world literature based around blindness. And it was the glabella, which was the number one area in 2015. And now if we look at the figures for 2019, it's actually gone from 25% to 56%, which is a huge leap. And I think one of the things that we need to think about is, why is there such a big leap from 25% cases of blindness to 56% of cases of blindness? You're more educated than me when it comes to the nose, and so I'm gonna leave that question with you, Raul. Why do you think there's been a big increase?
So number one, so initially it was the glabella, right? In 2015, It was almost 40% of the cases reported of blindness was the glabella, correct?
Yes.
Now I think it's around 27%.
It's dropped, yeah.
Yeah, it's dropped. Why? Why has it dropped? We'll discuss that in a second. But the nose went from 25, I think, to 56% of the cases of blindness reported. So it's a scary feature, I would say. It's a very, very scary statistic there. But why? So social media, as you said, so I think these treatments are becoming more and more popular, and it goes back to training. So we have anatomically an incredibly dangerous area here, the nose, because we have connections between both carotid systems there in the nose. We have a very limited amount of space there in the nose. So we know, yes, if you stay in the midline, if you stay below SMAS, you're safe. However, there are other factors that we need to factor in. Number one, surgery. Has this patient had surgery in the past? That means all bets are off with any type of injectable treatment. However, there is another one that I think we don't discuss enough, which is trauma to the nose. If someone has had trauma to the nose, bump in the nose, query, fractured nose, etc., at any point in their lives, it's the same thing for the anatomy. It's completely changed. And Lee, how many people have bumped their nose, basically?
I think lots. I think going back to your question on post-surgical rhinoplasty, I think one of the questions we should be asking as practitioners is, how many rhinoplasties have you had? Because they will have repeated, a lot of patients will have repeated rhinoplasties.
Yes.
So I think that's one of the questions we need to ask. And if they have had trauma, or if they have had a previous rhinoplasty, like you said, all better off regarding the anatomy. And one of the things that we need to do as trainers is to say, if you do come across those cases, you just avoid or you refer those cases to somebody who knows what they're doing, like an ENT or plastics. I think one of the things we do get scared of, not just complications, we have this inherent fear of referral. We don't like to refer our patients on because aesthetics is weird because we hunt alone, we're lone wolves, we don't like to refer.
Yes.
And until we get this referral pathway sorted out, then people are going to take on cases, I feel, that they're way above what they're capable of.
Absolutely.
So I think referral should be added to the list of treatment options when it comes to non-surgical rhinoplasty.
And your patient will love you for that if you refer them on. Now, in terms of the nose, I think that one of the things here that we must consider is the amount of space. If we know that our product has to be placed below the SMAS, we know that there's a very, very limited amount of space there. Now, it really depends on what tool you're using, if you're using a needle or if you're using a cannula. However, we must take into consideration the length of the bevel of the needle, 1.2 millimeters. And also we're using a very cohesive product there. So as soon as we start pressing on the plunger, then what happens? Then the product will migrate, will end up in one of the more superficial layers and cause risk and problems. So we need to adjust and, possibly choose a different tool. Some people like cannulas, some people like needles, but one thing we need to factor in there is the angle at which we're depositing the filler there.
I think you rightly said, and we discussed in the first episode about training and training for noses. How you were traditionally trained was an injection into the midline would seem to be the safer. I think we need to get away from the word safer. We need to think of as low and high risk areas. I really feel that we need to take the word safe or safer out. It's a risk always when you put an instrument through the skin. And midline was always traditionally the safer area. And anatomical variations, I think we've got to take distribution of the vessels out and really concentrate on the depth of injection, because as you said, this 1.2, 1.4 millimeters of bevel opening at the needle that's where the damage is done. So it's understanding depth and not just distribution. I think that's more of a constant that we have within anatomy when it comes to facial aesthetics.
Incredibly essential, yes, definitely. And Lee, moving on, so number 2 area used to be number 1 area, now it's the glabella. Why?
Yeah, well, it's like the pop charts, you have this movement due to popularity. I think, my opinion, I think the reason why glabella has gone down is because of education.
Absolutely.
And what I mean by this is every single conference that we've been to, we now have very eminent and very well-versed lecturers say, don't inject the glabella. It's the number 1 area for blindness, number 1 area for necrosis. There's no collateral blood supply to this area. Stop, don't be injecting. And I think delegates have really cottoned on to the fact that it's a super dangerous area. And you've seen the numbers go down when conversely the nose has gone up. And I think some of that has to do with things like the 10-minute nose job, the lunchtime nose job, the trivialization of something I feel is it is the number 1 now. It's the most dangerous area to inject filler on the face. Absolutely. So I think things like that, the reason why glabella's gone down is for education. And I think we're going to have to do the same with noses.
Yes, Lee, you're absolutely right. The glabella, every single conference you go to, everyone or anyone that you hear talk about the glabella is like, avoid the glabella. But here, this is an area where depth incredibly important, because we know that the risks are deep. So then if you inject that area, the product should be placed superficially, so that's one. And also we have a branch of the dorsal nasal artery lurking around there, which is the one that's been associated with complications there as well.
So when we look at the anatomy of the glabella area, you tend to look at the supratrochlear artery, but you'll also have ascending branches of a glabellar artery from the dorsal nasal artery. And as you said, the traditional thinking is these are deep. And again, it's how deep are they and how deep are they for? Did they change plane? And for the first 15 to 25 millimeters from the publications, we know that these vessels are deep. But if you look at lots of the literature based around surgical anatomy now, there are some superficial branches, even 2 millimeters. And you know, you did my you did my supratrochlear on ultrasound with Doppler.
Yeah, I did a Doppler ultrasound on Lee's temples and also on the glabella, and the artery was less than 2 millimeters there from the skin, which was scary.
So it goes to show you that we feel that there is no real safe depth to inject into the glabella. It's best avoided, in my opinion, for those who are not experienced, who are level of anatomy and level of complications management is low. Then I would completely avoid this area. I think number 3 is a really interesting area.
Yeah. Number 3 is the forehead. So it's an area which I think treatments are also on the rise. You know, they're becoming more and more popular. It's a really good area to treat, for example, in our female patients. You know, as part of the aging process, we start to see that bossing of the glabella and the loss of that nice convexity of the forehead. So here, placing filler under the galea in the forehead, 2.5 centimeters above the superior border of the orbital rim, is a good area to place it, and it's a very nice treatment to carry out.
I think also you've got to look at ethnicity here. This is foreheads are very popular in Southeast Asia just due to the shape of the skull, and I think that again this is an area which is increased. I think we've got figures now from 12 to 18%. I think these are the figures now. So we've seen a sharp increase in the rise of foreheads and popularity with it, especially in the aging process, female as well, with absolutely. The supraorbital bossing is a masculine feature, and we're trying to re-feminize because as we know, our female patients defeminize as they get older. So reinflation of the forehead is a treatment modality now because of this. Again, it goes back to profile. We never looked at profile with the forehead. So that's an interesting one, and there's a couple of different ways to approach. You know, you have your periosteal injections deep, and then you have your cannula. Again, this should be underneath the galea into that sort of what has been termed in the literature as the avascular plane. Number 4. Wow.
Number 4, yes. I think number 4 is wow. And the reason why it's wow, it's because it's the nasolabial fold. And what is one of the first areas that we actually treat when we learn aesthetics? What was the first area that you ever treated back in the
nasolabial fold? Nasolabial. So the prehistoric injectors like myself, who used to do all of their literature on slate chiseling away like the Flintstones, the first thing we did is we got a needle and we stuck it into the nasolabial fold.
But guess what? 10 years later, I started, and guess what? Needle, nasolabial fold, same thing.
But I understand the reason why. It's a straight line injection in the middle of the face. It would tend to be an easy thing to do, is to just place it underneath with no real information about distribution, depth, the facial artery, those type of things. And it's the 4th most dangerous area. And one thing I say is, I always have this conversation about temple injections. So I say to the delegates, who injects the temple, and half will put their hand up and the other half, and then ask them the reasons why. And they'll say, oh, it's a dangerous area to inject. And I said, do you inject nasolabial folds? And they say, well, yeah. And I said, well, that's the 4th most dangerous area relative to blindness. And it suddenly gives them a bit of perspective on all of the areas of the face do hold an inherent risk. Once you place that needle through the skin, it's game time. So you have to be completely aware of what's happening.
Absolutely. And here for the nasolabial fold, I mean, between 2015 and then the review in 2019, I think it increased about 1%.
Yeah. From 13 to 14%.
From 13 to 14. So what tips can you give people for treating the nasolabial fold?
Well, first and foremost, understand, and don't just understand anatomy, you have to respect it as well, because the nasolabial fold is a dangerous area to inject. So my is to use a cannula in this area.
Absolutely.
If you're going to treat the deep piriform space, then a needle down onto the periosteum would be the safer, and I can't say that word, is the lower risk approach to this, because there will be a deep lying branch on some, but be really aware of the signs and symptoms of vascular compromise with your patients. Understand those signs, and don't have professional denial. If you see blanching, if it's painful, then acknowledge that with the patients. Okay.
Yes.
So when we look at things relative to our injections, we've spoken about blindness. Now if you think about vascular occlusion, one of the interesting things is Samil Oztur did a review of all of the cases. I think it was 41 articles, 61 different patients, and the figure they come up with 0.001% or 1 in a million. And I think that number is way off. I think the risk for vascular occlusion is so much higher than blindness. And again, the commonest site for necrosis, surprise, surprise, nose. Commonest site for blindness within that publication, glabella. Glabella.
Oh, okay.
Yeah. So it was 50% of the cases within those studies with the glabella. So again, it's going back to this central facial area, the connection between the external internal carotids and the cutaneous branches of the ophthalmic artery, very, very close to the eye as well. So geographically, very, very close. So we can't just talk about blindness, we have to talk about the risk of vascular necrosis as well.
Absolutely. So Lee, I wonder if we're underreporting.
Absolutely. Yeah, I think that all complications are not reported to the authorities, but I think that a lot of them are not being reported to the insurance. I think there is a real risk of being red flagged by an insurance company that you're going to become some sort of insurance risk if you do have a vascular compromise or a case of visual loss or something like this. And I think this is that lone wolf syndrome. Professional denial, keep everything to yourself, not being referring, not reporting. I think we have an obligation to report. Then we'll have proper, if we give it to the insurance companies, every case that we have a complication with, then the insurance companies should hold that data to really help us on these risk areas. Because I think we should have an informed decision as a practitioner of which areas are higher and lower risk. And I know that just looking at your notes there is that number 5 is the lower lid and tear trough area is pretty much halfway in the top 10, and I think that's not just for blindness. I think this is probably the number 1 area for things like lumps and bumps or Tyndall or malar edema, just because of the anatomy. So what do you think about the tear trough, the lower lid area yourself as an injector?
First of all, it is definitely an area that we have to respect as injectors, like any other area. But here, I think that the most common complication that we're seeing here is complications related to the lymphatics here.
Yeah.
We know that we have, especially in the tear trough, these variations of layers, and we have 3 layers. So we have skin, muscle, and bone. So we know that the lymphatics, the vast majority of them are above the muscle there. So superficial placement of product there is a no because of that. And we do see lots of people walking around with malar edema.
Yeah, and I think David Funt's paper in 2011 really sort of puts it in beautifully description anatomically of this phenomenon of malar edema. And again, it comes down to the training, you know, a submuscular path of injection into the tear trough is the lower risk, because 90% of those vessels are above the muscle. So not just for the vascularity, but for treatment effects and predictability as well. Lymphatics is incredibly important. Going to number 6.
The temple, Lee.
Yeah.
The temple. Wow.
We have very different approaches on how we treat the temple.
Yes, well. Mine keeps on changing, keeps on evolving. I'd say evidence-based.
Okay, so the temple is one of those areas which I think injectors really would place higher. If you put this in a hierarchy of risk, then I think they put the temple much higher than the nasolabial fold.
And it's number 6.
Yeah, and it's number 6, relative to the risk of blindness. Yes. So you have 2 techniques here. You have the superficial, which I did back in the Stone Age. We used to get mixed results because of the rheology. We didn't have rheology right at that point. We have to admit it. There was papers by Lambros and Respaldo about mixing the hyperdiluting and we can't advocate hyperdiluting any of the hyaluronic acids available to you now. But it was the reason that they had to change the rheology was the tissue plane. They felt at the time the tissue plane superficially was the lower risk area to inject into. And I think it was from 2008 that the shift changed. The rheology of volumizing fillers, the cohesivity and the G prime, you couldn't facilitate placing those in the superficial layers. So what you had to do is you had to bury the product deep down. And Absolutely. I know you like the gunshot technique.
I like a combination, a layered approach. So yes, I do follow Dr. Trevedik's gunshot technique. So one up, one over, in the superior compartment of the temple. And one of the things that I always get asked is, that product goes on the bone. Well, no, we've done the dissections, haven't we? We've done the dissections, and that is an intramuscular injection, because we know that that's where the muscle is inserted.
Let me tell you something as well. Intramuscular injection, we know it's an intramuscular injection, as Raul says, that we've done some cadaveric work. But what structures are inside the muscle? It's the anterior and posterior deep temporal arteries. And again, going back to the ultrasound and the Doppler, you did my one up, one over, and surprise, surprise, what did you find deep?
A big artery we found there, right where we would place our deep injection.
So again, we're going to have an informed decision on what layer you're going to place it in. Are you going to go superficially? But if you do, you're going to use a cannula, you're going to use a lower G prime, lower cohesive filler to allow it to spread, or you're going to go deep down if that's your method of treatment of the temple. But be aware that people are saying this one up, one over is a safe injection. It's a lower risk to some people. But again, because this temporalis muscle is a huge, big working muscle, an industrial muscle I like to call it, it has to have an increased perfusion. And again, you've got deep temporal arteries that are perfusing the temporalis. So it's not a safe area to inject, in my opinion, especially on me. I find the superficial plane with a 25 gauge cannula for me is more of a lower risk. I can actually feel like I have more control rather than going in blindly from this point.
Yeah, no, I agree. But what I would suggest here, and the reason why I do both techniques, not necessarily on the same patient, is because I assess what my patient's needs are, and also I want to assess the thickness of the skin, because sometimes that lumpiness, we know that can last for a few days.
Yeah, I think with the superficial technique as well, you're going to get some vasodilation from the lidocaine. If you use lidocaine within the product, then you're going to have that. And again, that comes down to the patient consultation, education. You know, it's going to look slightly irregular for a few days. Moving on to number 7.
Number 7, cheeks.
Yeah.
Why?
Well, I think the vascularity here is, again, it comes from multiple sources depending on what part of the cheek that you're injecting into. So if we split the cheek into an anterior, a mid and a lateral part, then in the most medial part of the cheek, then you have the angular artery, the infraorbital, and then you start to move across, you start to reach different parts of the vasculature. You're looking at branches, zygomatica branch of the infraorbital. You're starting to get into the transverse facial artery areas, and traditionally this is one of those areas where you say it's okay if you inject down onto the bone here,
especially in the lateral cheek. Correct.
Yeah. Well, we're now knowing, and we're now seeing there's cases of blindness associated with the zygomatica facial foramen, which on some people you can have 4. Some people have none. Again, are you going to take that risk relative to where you're going to inject? So are you going to use more of a cannula now, sort of lateral into this? Again, the cheek can be a risky area to inject, especially with using a needle. I use a needle deep and the cannula superficial. So I'm with you with this. I'm a multi-plane injector. Relative
consensus.
Consensus. Relative to where we are in the cheek. Moving to number 8. Now it's quite an interesting one, because when I put this down, it was never. We never looked at this area of the face to treat.
True. Very true. So number 8, guys, in terms of risk of blindness, is the upper eyelid. So it's the medial portion, the A-frame deformity that we're talking about. Now, Lee, is this an area that you treat?
Nope. For me, I don't feel comfortable. It's not my area of expertise with it, and I think this needs advanced training with the oculoplastics, with the ophthalmics. I don't think that I would feel very comfortable doing an A-frame deformity with some dermal filler, even though I have a wealth of experience and knowledge related or regarding the anatomy. It still holds a huge fear for me, because this would be one of those things that I would refer. I would have no problem with referring an A-frame deformity to one of my colleagues who are more experienced than me, or who have a background in oculoplastics. That for me is great patient management. Referral on things that you don't feel comfortable with.
I completely agree with this one, guys. I would personally refer to one of my marvelous oculoplastic colleagues.
Now, something that I can speak about is risk area relative to blindness,
I know.
number 9.
I know. You seem to be a bit popular when it comes to injecting this area, and that is the lips.
Yeah, and it's relative to blindness. If you go to vascular occlusion, this would be probably number 1 or number 2.
I know. We don't have that information.
Do you think it's because of the volume of lips? Because I think they're the number 1 area that we inject with dermal fillers. That or cheek, one of the 2 areas.
I think yes. I think they're between both of them. They're number 1 and number 2, definitely.
And the vascularity here is incredibly variable. It's not linear. It's not a straight line like you see in anatomical text. And one of the things that we have to think about anatomical text is it's an average. It's an average depiction. Things you see within anatomical books, a straight line or pipe, it's not like that in real life. You can have a tortuous path. You can have it moving from tissue planes. And again, the lip is highly vascular because it's constantly moving. It has a large area, not just the red lip, it has the mucosa, the white lip, the tip of the nose. It's a significant vessel, and we know that it's bilateral, the superior labial. And it can be bigger on one side than the other.
Yes.
80% of it sits on the mucosal or the wet side of the lip. So we're starting to understand a lot more about this because it's so popular. And I think that myself, and you've done this many times, is we've started to look at the literature and we're starting to inject to give ourselves an informed decision on what is the safer or lower risk tissue plane. And from the evidence, I inject into the subcutaneous plane, or the 2% plane as I like to call it, because Kotafana's study tells us that you have a 1.7% chance of hitting the artery if you're in the subcutaneous plane. Now, if you go and take that opposite, and how I was trained back in the Stone Age was to place it into the muscle or behind.
Yes,
yeah.
Absolutely.
And this would avert and project the lip. And now we look at it and we're thinking 80% of those arteries, or 78.1 is the literature, is, wow, what were we doing at the time? Yes. You know, we were using our filler inefficiently. We're going to have to use a high G prime or more of the filler to push those tissue layers forward. Yes. Now we can place it, because the rheology is right in the subcutaneous plate. It only has to push one tissue layer forward. So lips, I understand. And I understand that it's really a technique-based problem, because I'm going to ask you about tenting, lip tenting. Okay, multiple injections into, I would say, one of the most highly vascular, highly sensitive, innervated areas on the face.
Yeah, absolutely correct.
So what do you think about tenting?
I don't do it. I used to, and this is what I found. I know you had a problem the first time you did it. You did tenting in the lips. So I actually did it for a while. And what I was finding is my patients, you know, they had these lovely results, and they were coming back with these bruises here in the cutaneous lip. A bruise, a very characteristic bruise there. And I was wondering, like, why am I causing these bruises? And then cadaveric dissection, I had a look at the caliber of the artery. So these branches from the superior labial artery, they're huge. They're huge. So I was basically skewering them.
Yeah, well, you are going to kebab through the tissue. And if you think about tenting, and there is, I think Ganam did the study based on the anatomic correlates between how you inject and where the filler's being positioned. And the lip tenting was shown to be 60%. It's incredibly close to the artery. So 6 out of 10, you're putting your patients, 6 out of 10, you're putting your patients at a risk of a vascular necrosis or vascular compromise in that area. I did it, and I had a huge area of blanching high up here, because I did understand the anatomy, but I didn't respect it. It was a technique which was going around at the time, and I thought I'd just have a go. And again, it was one of these things where I just stood back, looked at the anatomy, looked at the technique, and said, this is not for me. Again, with a multi-puncture, serial puncture technique, do you feel that you're going to increase every risk of complication with a multi-puncture injection pattern?
Yes, absolutely. More needles through the skin, potentially more complications, more risks.
More redness, more edema, more risk of hematoma, infection, blindness, vascular necrosis, all of those things. The reason why we're going on about lips is because this is where we see most of our complications coming from, is lip treatments, isn't it?
It does account for a very large percentage of the amount of vascular occlusions in the literature that we've seen.
Now, this last area for me,
it's crazy.
Geographically, number 10 the chin.
Yes.
It couldn't really be any further away from the eye, but yet we've got reported cases of blindness from the chin injection. And you think, how can filler get from the chin to the eye? I'm going to tell you something now. If you push that syringe hard enough, it can go to the eye from anywhere. It's a matter of pressure. Pressure is the enemy.
Yes, absolutely. And what type of products do we tend to inject in the chin deep? These are the very viscous products, correct?
Yeah.
So these are the products that we tend to place there. So that is the equivalent of pressing and creating more pressure, right?
Yeah, and the viscosity is important here because it's relative really to injection pressure viscosity. And if you look at the work, Kotafana's done some work based on pressure and how you inject, it's going to exceed facial vasculature, and it's this retrograde flow which is going to go back to the eye, and again it's all due to pressure. And slow, steady injection, I think, is the way forward in any area of the face. But chin, wow, just being so far away from that area. So one of the things that, looking at the literature now, and Greg Goodman and his consensus team for minimizing the risk of blindness, Aesthetic Surgery Journal in 2019, they looked at the areas of the face different. They looked at what we were discussing on very high risk, moderate risk, or low risk areas. And again, it sort of marries up really nicely with Bolesny's studies, 2015 and 2019. One of the interesting things about these guys in the consensus is they had, I think they had 22 plastic surgeons, professors, dermatologists, and then they passed that consensus on to the ophthalmics and interventional radiologists who concurred, and they come up with a strategy for immediate bedside management of blindness. So if you can access that paper, it's Greg Goodman's consensus paper on minimizing blindness and the immediate bedside management of that. It's a really interesting read. And when I say interesting, there's a very, very, really interesting part of it about aspiration. And I know that's a very controversial situation to not just us, but to you out there. And that's something that we're going to discuss in further episodes. So those risk areas, I would say, to round this off, that we've got to say that the whole face is a risk zone.
It is.
Based on the evidence that we have. And you're going to have to put those zones into a high risk or low risk. But you're going to have a risk. As soon as the needle goes through the skin, it's game time. Yeah?
Absolutely. Well, thank you very much, everyone, for joining us. I hope you liked this journey through the anatomical risks pertinent to blindness, so the top 10 high-risk areas pertinent to blindness. And please let us know your feedback and let us know what you would like to see us discuss in this show. And please send your comments over. And Lee, please tell people where they can find you.
They can find me on Instagram, LeeWalker_Academy, or www.leewalkeracademy.com. You can find us there. And Raul, where can we find you?
Well, you can find me on Instagram as well, at Dr. Chetto, that's DRCETTO. And thank you very much. So goodbye from Moscow, everybody.
Goodbye from Moscow. And one last thing. These talks are supposed to be informative and not alarmist. We're not here to scare you. So, as they say on Crime Watch, don't have nightmares.